everyone to the Hereditary Pheochromocytoma and Paraganglioma Syndrome, a Misnomer with Consequences webinar. During this seminar, all participants will be in a listen-only mode. There will be a question and answer session at the end of the presentation using questions submitted through the Q&A feature. Please remember that information provided in this web seminar is not intended as a substitute for your physician's guidance and care. My name is Sarah Rothschild, the VP of Program Services with the LifeRaft Group, and I am your moderator for today. I would like to introduce our presenter. Dr. Justin Annis is an associate professor in Stanford's Department of Medicine. Dr. Annis is a director and founder of Stanford's Hereditary Neuroendocrine Tumor Clinic, which focuses on the longitudinal care of patients and families with inherited endocrine tumor syndromes, primary, hereditary, Pheochromocytoma, MEN1, and MEN2. He participates in several neuroendocrine-focused patient advocacy research foundations, including the Pheochromocytoma Alliance, Neuroendocrine Tumor Research Foundation, and the NIH Pediatric Wild-Type GIST Clinic. I was very excited to meet Dr. Annis at the Wild-Type GIST Clinic a couple years back, and we're very excited for him to present today about his knowledge in this area. And I'd also like to thank the Pheochromocytoma Alliance for helping to promote this webinar today. So with that, I'd like to turn this over to Dr. Annis to begin.
Great. Thanks, Sarah. And let me see, I'll get my screen shared. And let's see. Okay. Sarah, if you could just confirm that it's sharing appropriately, that would be great.
I can see your slides.
Okay, terrific. So, yeah, it was really great. I think it's been a couple of years, well, at least a year or so since we met at the Wild-Type GIST conference. And participating in that group in particular highlighted the fact that there's this sort of artificial barrier between the Wild-Type GIST group and the sort of Paraganglioma focused individuals. And the purpose of my talk today, or one of the goals of my talk today, was to try to take a slightly different perspective, like a GIST-based perspective on the hereditary Parapheo syndrome. And then the purpose of that being to sort of highlight why they're really part of the same entity, and then think about whether or not we should be thinking about the name differently, and what the impacts of that would be. So anyway, on this first slide, of course, the first thing I do is to show an adrenal gland. So this fluorescent image that you can see is some of it's taken from the mouse work we do. And just to orient people a little bit, in the red outside here is the adrenal cortex. This is where a lot of your steroid hormones are made. And then in the middle, this green area, that's the adrenal medulla, and that's where your adrenaline and norepinephrine, epinephrine are produced. And when you have a pheochromocytoma, it's a tumor of these cells. And I just thought this image is really pretty, so I put it in the first page. Okie dokie. There we go. Okay. So just a quick overview of what I plan to discuss today. First, I'm just going to go over the basics of GIST. My thoughts about today's webinar was that most people are probably reasonably well versed in some of the basics, or most of the basics of the Pheo para syndrome. Maybe less, even though this is a GIST-based group. Maybe I assumed that more of the attendance would come from the Pheo-para folks. So I was going to go over some of the basics of GIST, in particular focused on wild-type GIST, which is the name given to the SDH, generally SDH-associated GIST, also called pediatric GIST. And then again, review the hereditary Pheo-para syndrome, and then present or take an opportunity to highlight this sort of center of excellence-based approach to disease care that the Pheochromocytoma Alliance is spearheading, and then present a brief introduction to some of the research questions my lab is working on. And the content of this talk is probably not an introduction or a 101 level course. I've tried to focus a little bit more on the molecular genetics and then try to raise some of the questions that I think are interesting in the area around the genetics of the disorder. Okay, let's get started. So GIST tumors arise from cells that are called the interstitial cells of Cajal. And these are cells which maybe you learn about in medical school, but probably after that, you really don't talk about them. And so I thought it was useful to just sort of review what these cells are. And they are cells that are within the muscle layers of the intestinal tract. As you can see here, there's different kinds, and they locate all the way up from within the top part of the surface with muscle, between muscle layers, and then actually integrated within the muscle. They're located in the stomach, the small intestine, the colon, and the esophagus. And then here, this is showing the distribution of where GISTs occur. So about half are in the stomach, 20–30% in the small intestine, and then 5 to 10% are in the colon, and 1 to 5% are in the esophagus. So the stomach really being the main player. Another interesting aspect of these interstitial cells of Cajal is that they have electrical activity. So functionally, it's not 100% clear what the ICCs do, but they're mostly thought of as part of pacemakers of peristalsis. And the reason why that's, or one of the reasons that's focused on, is because they typically here, when you have a muscle and the neuron that synapses on the muscle, this is sort of one paradigm, the nerve can control the muscle contraction. When interstitial cells of Cajal get involved, they sort of form in between the nerve and the muscle. And so they allow a spreading of the neural signal to multiple muscles to have coordinated contraction. So that's part, and they also have an intrinsic activity. So that's what they do. They sort of control, at some level, peristalsis and coordination. Now, GISTs are pretty rare. Actually, they have an incidence that's fairly similar to parapheos, which is about 10 cases per million people per year. And what I'll have you note is that like all the numbers that I give today, these are estimates, and depending upon what population you're looking in, you'll get different numbers. So any number that I say, that is a ballpark figure. But I think what's interesting to note is that GISTs overall follow are similar to other cancers where you have a low incidence in younger individuals. So there's 0.1 per million, so about 1 in 10 million people will have a GIST in age 8 to 20. But by the time you get to 70 to 80 years old, the incidence goes up. So this is up to 30 per million people. I think it's also worth noting that different people of different backgrounds, so whites versus Black individuals, will have different risks. It's thought that Black individuals are probably about twice the risk of white overall. Okay. And this is a point that I thought doesn't really get talked about, but it's fairly widely accepted, which is that if you take an older individual, meaning over the age of 60 or so, and you cut up their stomach very, very finely, and you looked for GISTs, you will find GISTs in roughly 25 to 30% of people's stomachs. And then this particular study is coming from gastric cancer sampling, but others have been utilized. And these tumors, these GISTs are, or gistlets as they might be called, are quite small. So they're all less than 1/2 centimeter in size. And this is an H&E showing you that the GIST is what the GIST looks like. This is standing for KIT, which is the molecular identification for GIST along with CD34. So these are true GISTs. And based upon the frequency or the size of their individual cuts, they actually estimate that basically almost every stomach might have a GIST if you look closely enough. And so I think here, this raises a really interesting question, which is, if GISTs are so common, meaning if you can find it basically in everyone's stomach by the time you're 60, why are GISTs so rare? So I think this is important because if we want to understand sort of the molecular basis of GIST and figure out how to detect them and what to do to treat them, I think we have to understand how it is that they're arising so frequently, yet why so few of them are going on to form tumors. And in fairness, very few of these GISTs actually have a mutation in the KIT gene. So that's maybe one molecular event that hasn't happened yet. Okay, how did GIST come to clinical attention? So like I said, so now if everybody has a GIST, you know, by the time, how do we figure out who actually has a GIST that matters or a GIST that's of clinical consequence? And for the most part, bleeding is one of the primary findings at the time of diagnosis, particularly in gastric GISTs, where it's about 50%. Many GISTs are found incidentally. This could be at surgery or by radiographically. If it's radiographically, it's probably clinically significant because then it's big enough to be seen. But we get a lot of GIST diagnosed through surgical resections or through other types of imaging that were done for other indications. And so then you wonder, is this just one of those GISTs that is never going to matter, or is it a GIST of clinical significance? Abdominal pain and discomfort is usually a later symptom. Acute abdomen, meaning sometimes the tumor will grow and interfere with the contraction of the intestine and cause a blockade that needs to be relieved. And then occasionally people will just sort of feel they have something physically in their stomach. And so I think here, again, it's worth pointing out that GISTs are actually quite difficult to detect radiographically. By the time you do see them on imaging, they're usually larger, and that's because most of the intestine or most of the GI structures are sort of folded on each other. They're moving. They have a lot of other neighbors that make, and there's content within the tubing of the GI tract. So overall, endoscopic ultrasound is really the most reliable way. And so it makes radio screening by imaging a real challenge. Okay, oftentimes when you hear about GISTs, the pathologists will describe them as either spindled, and then here you're showing a typical spindle-shaped GIST, and then here is the more epithelioid type appearance. And the reason that this is important is because even before there was molecular diagnosis, it was recognized that this epithelioid appearance was much more common in the GISTs that occurred in younger individuals. And this is part of how the name of a wild type or a normal appearing GIST came about. Overall, roughly 90% of GISTs are so-called sporadic. That means there's no gene being passed within the family. It just happened. And other family members are not at increased risk. And then roughly 10% are familial. And this number will change. Some people will say 85% sporadic, some people will say 95% sporadic. So it depends again on the population. But this frequency flips in pediatric population where the minority are sporadic. And that's, you know, thinking about age under 25 or so. And 85% are familial. So this familial group is generally called the pediatric or wild type group, but even if it can occur in older individuals, and it's really defined by the fact that it's KIT or Pdgf receptor mutation negative. And of this wild type group, about half of them are associated with an SDH X gene mutation. That means the SDH stands for succinate dehydrogenase, and it's an enzyme complex. And it's made of 4 different proteins, SDH A, B, C, and D. And about half of the wild type GISTs are associated with a mutation in one of these genes, but most predominantly SDH A. And then I'm going to come back to this probably a little bit later, so my screen sort of blocks my ability to see the slides. When GISTs occur in association with an SDH mutation, it's called Kearney Triad syndrome. Okay, it's a confusing name, and I'll come back to that. The other 40%, so you don't have a KIT mutation, you don't have a Pdgfra mutation, but you also don't have an SDH mutation. Frequently, what you'll find is if you go into the DNA of these tumors, that although their SDHC genes and all the other SDH genes are totally fine, the gene itself has been shut down by the cell. It's called hypermethylated. It's been closed off. And this, again, this is a sporadic case. It can't be passed from one generation to the other. And then it's called Kearney Triad because it occurs in conjunction with other tumors, which are paragangliomas and benign lung tumors as well. And then there's other genetic causes for like NF in particular has been recognized in association with wild type GIST. Okay, so this again, I'm going into detail, maybe just to sort of introduce you to the different versions or types of GIST. 75, and why do you want to know these type of molecular details is because it tells you a lot about prognosis, and it tells you about what treatments are appropriate. So again, 75% of GIST are associated with a KIT mutation. This is almost always sporadic. There have been a few families identified with KIT mutations, but this is really the vast minority. And then there are specific treatments which are pretty effective in this population. Pdgfra is another gene that is less frequently associated with GIST. These tumors almost all occur in the stomach, and they have also very sort of specific responses to different chemotherapeutic inhibitors, chemotherapy medicines. What's notable is that Pdgfra is slightly less or is less aggressive than the KIT. And then I'm going to skip another sporadic. There are other genes that can occur occasionally. And then I think what's important here is that SDH is roughly 10% of the gastric GIST. So now this is just thinking just about GIST in the stomach. It's about 10% of those. And I think here what's important is that the SDH associated GIST frequently metastasize. So that is, they often spread. And then when you look at the stomach, they're often multifocal. So there's not just one tumor. And then despite the fact that these SDH-associated GIST tend to spread early, they also tend to have a good prognosis. And there's different reasons for that. One is that it tends to occur in younger individuals. And the other, it just seems like it's a little bit less aggressive of a disease. And importantly, it does not respond to sort of standard chemotherapy treatments. And then NF1 in particular is probably the most indolent form of GIST, but when it is aggressive, it is poorly responsive. And I think also here, just to note, the SDH, I think the NIH did a really nice study where they looked at whether or not it's useful in SDH-associated GIST to do these aggressive resections versus sort of leaving the disease in place for the most part and treating as best you can symptoms and taking care of problems as they arise. And what they found was that sort of the radical surgeries really aren't beneficial. And so now there's real tension in the field of what's the right approach to these SDH-associated GISTs. In Stanford, I could say we tend to resect them and try to do minimal resections. Other places now maybe leaning towards even doing less. But I still think that there's curative intent as possible early on in disease. Today, I'm not really going to get into treatment and management, but I just thought that that's an interesting area to highlight because there's tension about what the right thing to do is. Okay, there's only one slide on NF1 GIST, but I bring it in here because I think, again, it raises interesting questions. So if you go into the small intestine, so NF1 associated GISTs are almost all within the proximal small intestine. And if you go into the proximal small intestine of someone with neurofibromatosis type 1, basically everyone will have a little gistlet if you look close enough. But a very small percentage of individuals, of NF1 individuals, actually develop tumors that go on to be of clinical consequence. So here I bring this up because I'm highlighting this fact that the formation of these small little tumors is one step, but the step to becoming a clinically significant and a health risk is another step that we don't fully understand. And I think, again, research needs to focus on understanding these different phases of the tumor growth if we want to understand how to prevent them and ultimately how to treat them. So that's all for NF1 associated GIST, really. Okay, and then here I wanted to take sort of a pathologist perspective on if you have a diagnosis of a wild type GIST, or if you have a diagnosis of GIST at all, what should be the steps that are taken to ensure that you have the appropriate care. So here we're looking at pathologic sections of a GIST. This is H&E staining, this is immunostaining for KIT, and then I'll come back to this SDHB immunostaining. So the first thing that should happen when a GIST is removed is to figure out, prove at the sort of molecular level that it is a GIST. And that's usually done by staining for a bunch of proteins, including KIT and DOG1. The pathologist should, of course, take care to say, like, to stage it. How big is it? What are the involved lymph nodes? Are the margins clear or not? And that helps to guide treatment. And then what's really become standard and is critical to do, now all GISTs should be tested at the molecular level for KIT and Pdgfra. So this seems obvious now, but when you go back, people have GIST for a long period of time. This may not have been done. And so if this wasn't done, then you're not sure exactly which type of GIST you have. And at Stanford, we've seen this come up relatively frequently, that people never had molecular testing. If this is the case, one thing that's useful to do or can be done is that if you can't do sequencing of the tumor for whatever reason, you can still have the tumor taken back out of the lab and stained for SDHB. And so here you're staining for SDHB. And what's important to know is that if you have a mutation in any of the SDH B, C, or D, or even if you have the Kearney's Triad or SDHC hypermethylation, the tumor loses staining for the SDHB protein. So this would be a way for an individual to say, oh, look, I have an SDHB deficient GIST, and this would be sufficient to prompt genetic testing. And so when we go back to our older samples and we do this, we're pulling out families that have SDH mutations, and then can do things like here, consider the syndromic significance, like looking for other tumors so we can have preventative care for that individual, doing genetic testing on the family to make sure we can do preventative care on other individuals. Okay, so then I just wanted to quickly recap the points that I've made so far. So in the case of a GIST, the KIT Pdgfr mutation status should be established. If there's no mutation, SDHB staining should be done. This is typical, although we'd also say if you have KIT PDGF mutation negative, germline testing should be done more broadly to identify SDH mutations. If there's no SDH, there are these other molecular events that can happen. Some of them are familiar and some of them sporadic. And then if the SDHB protein is gone, then either you have an SDH mutation and you can make the diagnosis of what's often called Kearney-Stratakis syndrome, or there's SDHC hypermethylation, which now there's still in the laboratory, like in my lab, we can do methylation studies, but clinically this is still hard to do. So it's often a diagnosis of exclusion. It's assumed that you have Kearney Triad, but there may be other reasons, other causes that we're not aware of at this time. Okay, so a paper which I found interest and I thought is interest potentially to the GIST community, it was Jason Hornick's group. I think that's not right. Okay, I'll skip whose paper it was because actually it's probably obscured in the corner. But what was found was that at the time, if you look at it when a GIST is diagnosed, and then you look either back in time or forward in time, you see an excess diagnosis of other cancers in this individuals. So basically, they argue that there's a 62 before you have an increased, I guess these are giving different numbers, but there's a 62 more than expected percent more tumor cancers in the period leading up to a GIST diagnosis, and about 45% more after the diagnosis. So if you look at sort of what this looks graphically, at the time of the GIST diagnosis is the peak of when additional cancers are diagnosed, but there are some that are made before and some that are made after. And to me, what this means, one could look at this data and say, oh, that means that GIST is part of a syndrome, or if I have a GIST, I'm at risk for other cancers. But I think the more likely and simpler explanation is that when you have a cancer, you undergo more evaluation and you're looked at more closely, and that means that you're more likely to detect an additional cancer. Conversely, if you get diagnosed with a GIST, you then also undergo more surveillance and additional cancers are likely to be identified. So this, again, is sort of one of the points that I want to make, is that many cancers that are identified are identified incidentally, and we never really, or we are unclear about what the actual clinical significance of this. And I think my argument is bolstered because when you move out more than 5 years on either side, these individuals drop down to baseline risk, suggesting that this is really just a detection bias. And that's sort of what you'll hear about, argued about mammograms are the same thing. It's sort of a needle or a thorn or a side of screening is this concept of detection bias. Okay, so now I wanted to come back to these names, which I've used, and these are the names which I'm arguing, probably we need to move beyond. Here, at least, identify that Kearney-Triad syndrome is basically the same thing, or is interchangeable with the hereditary Pheo and Paraganglioma syndrome, or hPPGL. This syndrome is primarily associated with paraganglioma. It can also result, these are SDH mutations, SDHX mutations. It can also cause kidney cancers with approximate similar frequency as GIST, and then much less commonly, there's pituitary adenomas and pulmonary chondromas. Thyroid cancer has been talked about, but it hasn't really borne out statistically. A separate but closely related condition is the Kearney Triad. This almost universally, and probably is universally, occurs, well, close to universally, in women who are young. We have no idea why that's the case, or at least we haven't proven it. The triad is of GIST, paraganglioma, and pulmonary chondromas, and it's caused by SDHC hypermethylation. So this is sporadic, meaning it's not passed on from generation to generation. I think it's worth noting that these wild-type GIST or SDH deficient GIST is part of either of these. And because there's a temporal component to disease, you don't, just if you develop a GIST and you just don't know whether in your one category or the other until you have more time, or unless you do molecular testing. So really these conditions are distinguished based upon molecular testing. Okay, and so what I wanted to argue today was that it would be much more informative to call these hereditary SDHX tumor syndrome, or in the case of SDHC hypermethylation, non-hereditary SDHX tumor syndrome. And the reason is that because the current nomenclature has a couple of different negative impacts. First, Kearney, I see here when I initially typed this out, I wrote Kearney complex. Kearney complex is a different condition, which is often confused by medical students, myself in this case, for Kearney Triad. I'm not going to discuss Kearney complex, it's a completely different condition. Instead, this should be Kearney Triad and Kearney syndrome. Names are less informative than using the hereditary, non-hereditary SDHX designation, particularly since they have phenotypically, meaning they have overlapping tumors. So I think we should use the name that's most appropriate to describe them. The other is that hPPGL reinforces this divide, this idea that the hereditary paraganglioma and pheochromocytoma is not associated with other tumors, but in fact it is associated with GIST and renal cell carcinoma. And naming it after a single tumor impedes the knowledge of physicians, trainees, as well as patients who are affected with either GIST and get this name of Kearney-Triad syndrome, or people who get a Pheo and then get the name of hereditary parapheo. So if we give them a same name, then it sort of unites them and brings them together. And that's what I'd argue what we should be doing going forward. I've been talking about Pheos and Paras, but I actually haven't introduced what they are. So I just wanted to take a moment to say that pheochromocytomas and paragangliomas are essentially the same tumor. They're both derived from neural crest cells that sort of migrate along the paraspinal axis, and some of them migrate into the adrenal medulla. Now, more recently, we've found that there are other sources or progenitor cells for these for these neuroendocrine cells, chromaffin cells, but I think it's easier for now not to focus on that. And say to understand that pheochromocytomas occur within the adrenal medulla, and paragangliomas are basically the same tumor that occurs anywhere else. And then when they occur in the neck, the surgeons have a different name for them, and they're called glomus tumors. But for our purposes, they're basically all the same. And many people have argued that they should just all be called paragangliomas. Either a functional adrenal paraganglioma would be a pheochromocytoma, or a non-functional head and neck or vagal paraganglioma would be, anyway. And that's the arguments that the nomenclature should be cleared up in this case too. Okay, so the focus of this talk, or a lot of the emphasis on this talk, is on the molecular details. I think, again, I'm assuming that this is mostly a more nuanced and advanced crowd. And so I also thought it'd be worth understanding some of the details of tumorigenesis, or so that you could sort of put this into a framework. So first, talking about KIT mutations, or Pdgfra mutations, these are the sporadic tumors. And so why is it that these genes cause sporadic tumors and the other genes cause familial? The main reason is that these genes, KIT and Pdgfra, are what's called proto-oncogenes. That means they are the gas pedal for cells to divide. Normally, they are well controlled, because when the receptor, when these genes receive the appropriate signals, they then tell a cell to divide. What happens in GIST is that one of the copies, so you have two copies of every gene, one you came from mom, one you came from dad. There's a mutation in the KIT or Pdgfra receptor, or the gene, that then makes the receptor protein, and then that turns this protein on. So the gas pedal is pushed down, and the cell is constantly being told to divide. So this is what we call an oncogene, because when the gene has an error in it, it becomes oncogenic. It's a gain of function mutation, meaning it turns on the gene. And in this case, one mutation is sufficient to promote cell division, and that's usually why oncogenes are part of sporadic tumors, because if you had this in all the cells of your body from the time of birth, you generally wouldn't do well. Now, I've said there are some rare c-KIT familial forms, and those mutations do exist, but it's not the rule. By contrast, the SDH genes are what's called tumor suppressors, and typically we think of tumor suppressors as brakes on the cell growth. So like I said, you have two copies of every gene, and if you have one SDH mutation, this is a person who inherits an SDH mutation, they still have, or you still have, a backup copy of the SDH. And since there's a backup copy, that copy as a brake is sufficient to keep the cell in check, because you've lost the function, meaning that you've lost, or the mutation affects one copy of the gene or one allele, but the other one is fine. And so what you have to wait for in order to get a tumor is a second hit. And this second hit usually happens when a cell is dividing and is random. So you don't know which cell it's going to happen to and whether it happens at all. And that is why we will introduce the concepts of penetrance and then another expressivity. So penetrance is important because when you have an SDH mutation, that means you have one broken copy, one intact copy, and that second hit is random. The frequency with which that second hit occurs is what's called the penetrance. Some disorders have complete penetrance. Everybody who has the mutation goes on to get disease. for the SDHs, we have what's incomplete penetrance. Only some people will get the disease. So again, not everyone with the gene mutation has a problem, and whether or not you develop the problem depends upon the risk of the second hit. Okay, and so then here we get into the different penetrances of penetrance of the different SDHA, of the different, SDHX genes. And it turns out that the penetrance of SDHA, B, C, and D are all different. And this is a really nice study which used population genetics to sort of figure out what the penetrance of the different mutations are, specifically for paraganglioma. And I think this is important because it may surprise you in some ways, or maybe not in others. So for SDHA, your lifetime risk is estimated to be, if you have an SDHA mutation, your lifetime risk is estimated to be about 2%. So that means in 100 people, 98 people with SDHA mutation don't get a tumor. 2 of them get a paraganglioma, 2 of them will. So it's a big increase in the risk of the population, which is 50-fold, but still the individual risk is relatively low. This is why most people, most families with SDHA mutations, maybe one person's affected and then no one else, or someone did genetic testing for breast cancer, which is quite common, and then they found an SDHA mutation. And that happens very frequently in my clinic. So probably the most frequent consult is we did testing for these other genes and we incidentally found a mutation in an SDHA. SDHB has a higher penetrance, about 20% lifetime risk if you have an SDHB. So here you see about 1/5 of people will have more than one tumor. That's a related concept. And most families will have 1 or maybe 2 affected individuals. SDHC, the penetrance is even lower. SDHC is extremely rare. And then SDHD is higher. And their families frequently will have individual affected, although it wasn't included in the study because the inheritance pattern is more complicated. Okay, a related concept is something called expressivity. So what is expressivity? So this is that the same SDHX mutation, so if I have an SDHB mutation in my family, it can be some people, many people, actually this fractionally is wrong, right? Most people will have no tumors, but other members of the family will either develop a paraganglioma, someone might develop a kidney cancer, there's the same mutation, and then someone might develop both a GIST and a paraganglioma. And whether you develop one tumor type or another is completely dependent upon this random second hit. And so some genes like SDHB are more likely to cause a paraganglioma than a GIST, so there's some bias here. But the idea is that if you inherit an SDHB mutation, you inherit a fixed risk for paraganglioma, you also inherit a risk for GIST. And because you've inherited both of these, I think the idea that currently that some of our communities are somehow separated feeds into this idea that these individuals have different diseases when in fact they have the same condition, which is an SDHX associated syndrome. Okay. Okay, this slide sort of messed up a little bit. I sort of want to get now at like some of the questions that people would ask themselves. So related to expressivity. So if I have an SDHX tumor, so let's say I have a paraganglioma, am I at higher risk for another tumor? If I have a GIST, am I at higher SDH, am I higher risk for another tumor? And so sort of a related questions or closely related question is that are some mutations worse than others? So they're all loss of function generally, but are some more loss of function than others? And actually, in truth is that we don't know the answer to this question yet. It seems that maybe some are slightly worse, but it's not, there's not profound differences yet, with the exception of a few mutations. Sort of also a related question, are there good families? Like my family has all these tumors, this other family has no tumors. Is my family a bad, quote, bad family? And again, here, it doesn't fully seem so, But these are the type of questions which need to be more thoroughly addressed. And I wanted to share this relatively complicated experiment with you guys because it sort of gives an insight into whether or not, if you have a tumor, whether or not you're at risk for another tumor. Okay, so in this study, we're looking at the individuals who are 60 years old, and everyone recruited into the study had a paraganglioma, and then added onto the study were the family members of the individuals with the paraganglioma. So you have people who are considered probands, those are the people with the tumors, and then the non-probands, those are the family members without the tumors at the time of enrollment. So if you look at paragangliomas, in the whole population of the study, it was 45%. Okay. Then if you look at the paragangliomas in the non-proband, so you remove the people who already know had a tumor, and it was about 18% of them had a tumor. And that's very consistent with the penetrance that I told you, about 20% of people with SDHB will develop a tumor. Okay. So here, clearly, the proportion of individuals who have tumors is much higher here because we're including all the people that enrolled, and lower here. But they were enrolled in the study based upon the presence of paraganglioma. Now, what happens when we look at their risk of kidney cancer? So a different tumor that had nothing to do with their enrollment. What was found is that the risk for kidney cancer is the same in this very high risk paraganglioma, meaning this very frequent paraganglioma population versus this lower paraganglioma population, which means basically that the risk for kidney cancer was totally separate from the risk of paraganglioma. And this argues that in general, there aren't really bad families that we can pick out, at least on this large test, or this scale of experiment. It also says that your risk of having, if you have one tumor, the risk of having a different tumor is just based upon the penetrance of that gene. It has nothing to do with the fact that you have a tumor already. That's a conclusion at this point. I don't think that's 100% solid, but that's the conclusion that looks to be most accurate. Okay, and so then I'd like to hit upon another area of confusion, or not necessarily confusion, but a complicated area for people to understand this question. If you have an SDH diagnosis, you want to know, okay, what are my risk of having different types of condition? And so if you're given the diagnosis of an SDHA mutation, for instance, a typical chart will say that you have a relatively low risk or you get a 1+ for pheochromocytoma, you get a 3+, which is a higher risk for a GIST, and then so forth. And what's complicated or problematic about these types of graphs is that they've come to this conclusion by looking at the relative frequency of SDHA mutation or B mutation among pheochromocytomas. So if you look at pheochromocytomas, there are many more SDHB associated tumors than there are SDHA mutations. But the problem here means that the 3+ in GIST, it only means that SDHAs have more GIST than SDHBs. It doesn't tell you how frequently a person with an SDHA mutation will actually develop a GIST. And so this, unfortunately, is the framework with which we've been working in for years now, because we didn't understand, or we didn't have numbers for the relative penetrance for each of these mutations. And now we're starting to fill in this chart. And a point that I wanted to make was that if you have an SDHA mutation in the United States, these are rough numbers, but the average number of SDHA-associated paragangliomas is roughly 50 to 75. I have to move this. Whereas the SDHA-associated GISTs are more or less a similar number. So here you can see we give 3+ to the GIST and a 1+ to the pheo, but in fact, the frequency of listed an SDHA individual will develop either tumor is basically equal. So what we really want to have filled in, and this is early days, we're still filling in this chart, is what is my actual risk? And so if you look here, if you have an SDHA mutation, your lifetime risk of a paraganglioma is roughly 1 to 2%. your lifetime risk of a GIST is roughly 1 to 2%. They're pretty equal. And now these are independent. So you have to sort of sum them up to know. So overall, if you have an SDHA mutation, there's roughly maybe a 2 to 4% chance that in your lifetime you develop a problem. And that's, at least in my, is relatively low. SDHB is a higher penetrance. And I think because paraganglioma is the predominant risk, this is why the focus of the syndrome has been on hereditary pheo and para. And I think, again, I've said this a couple of times, that we should start moving away from this concept. Again, I'm backing out here. I'm saying, okay, these are approximate numbers. Don't take them for fact. And then also, there are gender different. There are other types of, there are probably background differences in terms of what your background is ethnically, as well as if you're a man or a woman. Okay, actually, we're running quite short on time. I think I'll just go through this quickly. Because each SDH mutation is associated with different levels of risk, our guidelines for surveillance are different. I won't go through these in detail, but you can imagine that you threshold your surveillance based upon what your perceived risk is. I also note that there's really no GIST-based surveillance. In my clinic, I use a CBC as a very indirect way of tracking whether GIST, because so many SDH associated GIST present, they're all in the stomach and they present with anemia. So this is sort of an indirect soft sign. But I can tell you there's lots of causes of anemia. It's not a very specific one. So I'm not arguing for the utility of this. I'm just saying this is my practice. There's a variety of studies that are coming out now that have highlighted the utility of image-based screening. So if you have an SDH mutation, is imaging useful? I think Lauren Fischrein and Samantha Greenberg just published a nice study reinforcing this earlier one, saying, yes, you should be doing surveillance. No, we don't know the frequency, but it detects tumors before paragangliomas and GIST. I think there's a GIST highlighted here in this individuals who were being surveilled just because they had an SDHB mutation. They had no history. Like I said, GIST detection is not great, but it can be found. And then again, because we're short on time, I don't want to leave time for questions. This is a really nice study that was done, which actually showed that genetic testing had a real impact on when the size of tumors that people found, the size of metastases when we found. So if you had genetic testing and were told about it within the first year or a few months of diagnosis, you did better than if you found out 7 years later. And complications are much down, and then survival was much better if you receive your if you have genetic testing and receive the results. And so genetic testing just in itself matters, and it probably is because you get better surveillance, you get closer medical contact, and problems can be headed off before they're too late. Okay, I just wanted to take a moment to highlight the Stanford endocrine oncology model of approach to SDHs and other hereditary endocrine tumors. And again, I'm a plug for the Center of Excellence program, which is being developed by the Pheo-Para. I haven't got my application in yet for Stanford, but we're going to do that. And I think this is really important for patients with rare disorders. And the idea is that if you have a rare complex condition, you need to go to some place that has a multidisciplinary team that's fully familiar with all the ramifications of the condition, has formal case reviews like tumor boards, and has active clinical and basic science research, so you can have access to the state-of-the-art knowledge and the best possible treatments. This is the sort of the shape of our endocrine oncology program. It has a clinic coordinator to make sure that patients are followed up on appropriately. I run the genetics aspect, which includes genetic diagnosis and a lot of the imaging and biochemical screening, endocrinology management for, let's say, you lose both your adrenal glands, oncology, and we all meet together and have a clinic together. And every patient doesn't see everyone, you see who's relevant. But because we're in the same room in a non-COVID world, it allows us to discuss cases and have informal interactions to run by each other. I think enhances patient care. And then there's pediatric endocrine group that mirrors us, the oncology, sarcoma oncology group for that just mirrors and interacts with us. And then we have all these sort of dedicated specialists, which is critical for giving patients the best possible care. And then we all attend the tumor board and we all participate in research. And then I also note that dedicated anesthesiologist is important because of the complexity of doing surgery on hormone-producing tumors. Okay, running really late here. Sarah, I can keep going?
Yes,
or I can...
we have a few questions. I think people really want to hear about your research, but we also want to ask questions. So see if you can just finalize your slides.
Okay, all right. So I'll do this really quickly. So this is just how the tumorigenic mechanism, and this is a structure of the SDH complex where you have A, B, C, and D. I'm not going to go into this. I think this is actually what drove me into this field was this idea that we have no idea why a mitochondrial enzyme would cause tumors at the time that I started, and now it's emerged that actually, let's say if you have a succinate dehydrogenase mutation, you get this buildup of succinate, which is a metabolite, and then that's somehow messes up the energetics of the cells and drives tumors, and is a really focus of research going forward. I think I'll stop. I mean, to rush through the research is a little bit hard. I think I'll just maybe I can just give the headlines. Because we're detecting so many mutations just through sequencing and we don't know whether or not the mutations are of significance, my lab has developed a way of just testing. So SDH-A, B, C, or D, you get a mutation, we can test in the lab whether or not the protein is functional, and this helps to categorize patients. We're looking for drugs that are selectively targeted SDH deficient cells. This is something called synthetic lethality, and have developed chemical screens to identify these medicines. We're looking for markers to identify prognostic markers so that we can distinguish who is at highest risk for complications and who isn't. And to do this, you have to collect hundreds of tumors, which we've done, and then array them and then stain them. And then, of course, I think really to make progress, we'll need proper animal models, and my lab is working on those. And so then I'll stop there. Okay.
Ooh, that was a rush. But I mean, Dr. Annis has, yeah, I'm sure he'll make himself available if people have follow-up questions about his individual research. Can you see me okay? Because my internet was going out.
You're coming in.
Can you hear me?
You're okay.
Okay, well, let's do our best here. So the first question is, my family has SDHC gene mutation. My sister, who has been tested for SDHC, was apparently negative and has an adrenal tumor that may be affecting her blood pressure. She also has metastatic breast cancer. Even though her SDHC mutation test was negative, please advise, could it be an SDHA mutation?
Yeah. So yeah, this is right. So giving clinical advice in complicated clinical scenarios is very hard to do over the internet. The first thing is to figure out what the adrenal lesion is. Are you sure that it's a pheochromocytoma? Could it be something else? And the differential there is quite large. Let's assume that you've firmly confirmed that it's a pheochromocytoma or making norepinephrine, whatever, you know that it is. Yet that person, if they had site-directed testing for SDHC, should have expanded a screening panel. Actually, a person who had breast cancer usually gets some type of genetic screening panel, and it should recover all the SDHs and other genes. And that's because you have the same parents, but you get a different assortment of genes. And it's possible that multiple genes can run in families. So yes, if you confirm that it's a Pheopara and she's SDHC negative, you look for other explanations.
Got it. Are patients with SDH-associated tumors at a high risk if they get COVID?
Yeah, so this question comes up and has been answered in a variety of different ways. So your primary risk for COVID complications are, of course, related to your comorbidities and your age. Having an SDH mutation in itself does not confer, meaning I have no tumors, but I have an SDHB mutation. That does not confer an increased risk on its own. Again, your cells are basic. We think your cells are essentially normal as long as they have the backup copy. So an individual who has a hormone-producing tumor is a different category. They're higher risk because that can be complicated.
Okay, you know, I know we're at 1 o'clock and that is the end. I'm just gonna honor some of the questions that came in. So whoever wants to stay on, you know, feel free, and then we'll end a few minutes into the hour. So the next question is, I'm waiting for results from genetic testing for my 3 little girls, ages 5, 3.5, 9 months. I'm SDHC with an awful vagal paraganglioma. If they have the mutation, how can I help prevent the random second hit?
Yeah, so usually with individuals with SDHC, I start with the numbers. In almost all SDHC mutations generally occur with a single person affected in the family. Very rarely we see multiple, because the reason is because the risk of tumor is quite low. So the first thing I try to do is reassure you that I think it's extremely unlikely that your girls are going to be affected, although of course, actually, it's unlikely. Like I said, it's probably, you know, in the range of 10%. So what can you do to prevent a second hit? There's not that much you can do. You can lead a healthy life. You can try to, if we understood better why that second hit occurs, then maybe I could give you more directed advice. Now I can say, they shouldn't smoke. That's pretty straightforward. There's a lot of tension in the field about living at high altitude, not living at high altitude. And different experts will give different advice. I say if it's convenient for whatever reason not to live at high altitude, fine. If you live at high altitude, I think the evidence that's substantially increases your risk is there. Meaning that forget SDH, your risk for having a pheochromocytoma or a paraganglioma is probably slightly increased if you live in the high peaks of the Andes. But if you have an SDHC, it's not clear that it increases your risk of SDHC-associated tumors. So I would say you have to decide what your risks are yourself, but I tend not to suggest upheaval of your life.
Right, and definitely speak to your practitioner about that.
Yeah.
This is a big question, but I think it gets asked a lot. Is there a cure in sight for SDH-associated tumors?
I don't, so yeah. So when a cure is in sight, that usually would mean that we have something in hand that is so promising that we think this is going to work. And I would say no, that we're not there yet. On the flip side, I think the amount of effort and investigation that's going into this area has substantially increased. And so the likelihood that we develop better and better and more effective medicines is increasing. So I still think we're a ways out from a cure per se, but I think we'll see incremental progress accelerate in the coming years.
I think that's a really good segue to you and your research and your lab and your animal models. I think that people really want to learn more about that. So is there a website about your lab? I see people, there's somebody in Canada who wants to learn more. There, you know, people want to know about, specifically you mentioned about looking for medication and treatments that can be a positive impact for the SDH deficient cells. Maybe you can just sort of help summarize, and we can't get to everybody, but maybe there's a way that I can get people in touch with Dr. Annis to follow up with their questions. But let's conclude with what is in sight? What is the hope for our future and what you're doing in your lab for this community?
I think, so the research sort of that I do sort of focuses on, I think there's short-term goals, which is when people get diagnosed, how do we give them better information about what they should do to maximize their chance of quality of life, to maximize their chance of their children having a quality of life. And so those are mostly, like we said, better diagnostics, better prognostics, better understanding of genetics. Those are informative. I think the bigger picture, what my lab is trying to go after, and I think has to happen in a basic science lab, in my view, is this type of drug discovery and mechanistic discovery. And I think with this type of fundamental research, we can identify proper targets and then use medicinal chemistry, use our known approaches to make the drugs that we need. Right now, we don't have the models to really discover even what the proper, what our drugs should be targeting. How should we be killing these cells? But I can say for SDHs, those cells are different. They look different when you look at them under the microscope. They behave different when you look at their metabolism. There is a weakness, an Achilles heel within them, and it's just a matter of time before we find it. So I am very optimistic that we'll find a way of selectively targeting these cells.
And for patients on this call or going to listen to this recording who want to do their part, would it be helpful if they have surgery to donate tissue to your lab or to other researchers in the field to help create those models to then show, like, test with drug discovery?
So for a lot of our work, and I know they're collecting the tissues is always useful. One of the issues is if we collect it from outside the system is we have less information, the sample preservation isn't always the same, and there's a whole host of reasons why we tend to be biased towards our own collected samples. But yes, there are a variety of active programs, not necessarily, but where people are actually trying to collect live cells. And as those programs come up, participation is really important. And participating in things like this, where you're learning and being active in the field and advocating, is really one of the biggest things you can do for the field, being aware and being a participant.
Amazing. I feel so bad that we can't get to everybody's questions, but I definitely want to honor that you asked them and find a way to follow up with you with answers. So stay tuned to the folks who submitted your questions. I want to thank Dr. Annis today for your presentation and educating the community about, I guess, this whole system of diseases and how they relate to one another. And I'm glad that all of you could join and learn more. And we hope to continue series of these webinars in the future over the course of the year. So stay tuned for that. Thank you, Dr. Annis. Thank you to the Pheochromocytoma Alliance for helping to get the word out. And everybody have a lovely day. Bye.